what would be a different way to do it? And I'm going really out on a limb here. I'm saying neither of those belief systems can produce the care we need. Not professional dominance, just trust me, I'm the doctor, and sit down and listen, era one, or era two, markets, combat, accountability. I as I've said and written, I don't believe markets are the answer in healthcare. I don't think it will work. And I certainly don't think scrutiny and accountability and ticking boxes is going to work. So I tried to devise what I call era three. What would be if I could wave a wand and we would just pause and sit down and think about our belief systems, what would we change that would lead to a new kind of era, new kind of ethos? I propose 9 steps. I say 4 are backing down steps. They're away from era 1 and era 2, and 5 are leaning in. The 4 backing down ones are, first, measurement. The era 2, especially this era of accountability, it has led to immense amounts of metrics. You've seen some recent writings about that. Bob Wachter's editorial in the New York Times, the recent work at CMS to kind of reconsider the metrics for meaningful use, and the announcement just a couple of days ago of an alignment of metrics between AHIP and CMS. That's good. I'm saying stop it. Let's back down for the amount of measurement. The second backing down is about incentives. I just don't think that we should be working with these complex incentive systems for individuals, at least for individual physicians and nurses and others. Maybe organizational incentives, yes. But we are driving doctors and nurses crazy with very complex incentive systems they don't understand and don't speak to their intrinsic motivation. So I say abandon complex incentives for individuals. The third was, can we get our mind off the money for a minute? And this is, I think this sounds naive. It isn't. I think if you look at mature industries and the whole quality movement globally, there's an idea. The idea is if you meet the needs of the people you're helping, the money comes then. You don't focus on the top line or the money. You focus on the quality, which is the degree to which you're meeting need. And I believe healthcare needs that confidence and that agreement that we're going to work on suffering and its reduction, and the money will follow. And I know that sounds, in a board of trustees or a finance system, that sounds naive. I think it's the right way to think. The fourth is around era 1, prerogative. My father, I remember, he was a doctor. He was a great doctor, I think, but he was the doctor. You did not talk back to him. He said, "I'm the doctor. I decide what happens." That's his era. The era 3, I think, is much more co-production, co-design. We're in it with patients. The other 5 elements are then the step into what? Step into, first, improvement science. What's going to replace markets or professional trust? You have to have an alternative. I have an alternative. Scientific improvement. It's the use of modern methods to look at what we do and continually make them better. We know what that does. That's what WIHI does. But it's not being treated with the seriousness and the discipline that it ought to. Most medical students don't ever hear anything about quality improvement. They could. That could be part of professionalism and leadership and management. Transparency, although I'm arguing decrease mandatory metrics, the counter-argument, the other part of the plan is turn all the lights on, complete transparency. The amount of money and time we spend hiding stuff doesn't make any sense. So I say let's make everything known. If we know it, the world can know it, subject to privacy concerns. Item 7 came from Bob Waller, former IHI chair of the board, former chair of Mayo Clinic. Dr. Waller said to me once, everything possible begins in civility. I have deeply believed that, and I think that the incivility you're now seeing in the Washington political arena, you watch what it does, how erosive it is of actual dialogue. I think there's a behavioral issue here. It has to do with the way we deal with each other. So I hope the day comes when I never, ever hear a doctor talk again about green eye shades or a manager talking about herding cats. That is not okay. What's okay is saying, hey, we're here together. There's a patient on the other side of this system, and we need to help them. The 8th idea is patient-centeredness, but taken to the full limit, where we really do listen back from the people we're trying to help. In fact, I think they should be in governance and in control. And I particularly believe that has to do with excluded minorities and inequality. I think it's time for us to listen in a much more thorough and complete way and actually, it's not even partnering, it's becoming servant leaders in which the patients and families are really the boss. And I've written and believe that. And the last one, item 9, is kind of an orphan. I don't know where to park it, but it's about greed. Because of this clash in era 1 and era 2 and all sorts of other reasons, we are a greedy system. And you can see it most famously now in the pharma world where the prices that are now being attached to drugs, I don't care how many economic arguments you're going to throw at me. This is insane. These drug prices do not belong in the landscape of a compassionate society. And it's got to stop. And that's not just drugs. It has to do with the top-line driven attitudes in care. They're not generally bad people doing this, but we've trained ourselves to just ask for more, and it isn't going to work. And I think that there have to be stops placed. Obviously, the default is regulation, price controls, and serious regulation, saying you may not charge that. I'd prefer to see something short of that, and I call for a voluntarism. I'd like to see the stakeholders meet and begin to articulate rules for fair pricing, fair profit, and stick by them with severe consequences or violation. But greed is killing us. It's killing our trust. We don't want to throw away Era 1 or Era 2. They both have aspects we should keep, the professional pride, the scientific foundations, the beneficence, the idea of professionalism belongs from Era 1. We need to keep that, but not opacity, not self-protection, not domineering professionalism. And Era 2 also has good aspects. I told you, I believe in transparency. I think payment is screwy and needs to change. You have to have payment, so let's just make it sensible so it supports the well-being of the people we're trying to help, and patient engagement. Those are all ideas from Era 2, but not incivility, not combat, not over-measurement, not over-reliance on incentive, and not forgetting that relationships and healing are human relationships. They're not transactions. They're relationships, and relationship-based care is what we really want and need. So that's my brief. I could be wrong. I'm sure I'm wrong. I just don't know where. But I think I'd like to raise that conversation about a new era.